this is Dr. Mark Contos with daily coverage here in Chicago, and with me today is Dr. Dee Stephenson, and she's from Venice, Florida, and we're going to talk a little bit about post-refractive cataract surgery and kind of getting the result that we want with those patients. Dee, thanks for joining me today. I really appreciate you taking the time to talk about kind of a group of patients that we're seeing an awful lot of now. You know, both you and I have been doing LASIK refractive surgery for a while. Those patients are all coming to cataract now, which is something that everybody's experiencing. And you've got some information about how you're kind of dealing with those things. So let's talk a little bit about that.
Thank you for having me. I appreciate it. You know, it's interesting because, you know, every day I have new patients with post-LASIK or RK. So, you know, finding the holy grail and getting them to be LASIK-like outcomes for cataract surgery has become a challenge. I have had quite a bit of experience with intraocular aberrometry, or aura, with Verify. So this has been kind of my go-to instrumentation for all my surgeries. But I did a little study just retrospectively on 20 eyes, 14 patients, 8 of them were bilateral, 6 were unilateral. I used 2 different kinds of toric lenses, the Trulign, Bausch & Lomb's Trulign, and the STAR's toric lens. The interesting thing, you know, you go through you know, methodology and, you know, methodical methodology, if you will, with all the formulas, you know, for post-LASIK or post-RK patients. And historically, you know, the results are not great. They're not terrible, but they're not great. But only about 60% of patients achieve within a, you know, reduction of less than half a diopter or less of astigmatism residual. And using aura has helped me raise that for myself, and I'm about at 80% or higher with using aura. In this particular small study, you know, as time goes on, I will add more patients, and you know, most of these patients, however, in the 20 that I had were post-LASIK, myopic LASIK. A couple were hyperopic LASIK and a couple were RK. And as we all know, the hyperopic ones and the RK ones are a little more difficult. What was amazing to me was that I changed the power of after going through all those formulas, I changed the power on the table 70% of the time by using aura. And, you know, some of those patients may not, if you use just a toric calculator, per se, and put their, you know, information in, you're not going to get it. Yeah. So, you know, that's what the amazing thing is, that the intraocular aberrometry can really, you know, improve your game. 100% of them uncorrected were better than 20/30. Yeah, so, you know, this is what my continuum is going to be. So I really want to look at it retrospectively in a larger group in the near future and really talk, you know, get to the point where I can actually advise other colleagues on, you know, what's the appropriate thing to do. So it's a, you know, it's an open field for us with all the post-refractive.
For the patients that you were making some of those changes on, were the lens changes generally spherical power changes, or did you make any changes with cylinder?
Both. Yeah. Both. Significantly more change with the spherical power, but also change with the toric power.
Yeah, and I think that's interesting because, you know, we would kind of expect, you know, we all know that occasionally we're not going to, in this group of patients, we're not going to get the sphere right, you know, some of the time. It's just going to happen. Yeah. But we probably always assume we're going to be pretty close with the toric, or with the astigmatism correction. Right. And when you can see on the table that maybe you have to even change that number, that's kind of an interesting
Well, and as you know, with, you know, the aberrometer measures posterior corneal astigmatism, and that's, you know,
that's where that comes in.
That's where that comes in. So, and I think in a, you know, post-refractive patient, that's, you know, that's so it's hidden because we've altered the cornea so much. So it even plays a bigger role. And, you know, you can look at a refraction and compare your refraction, your manifest refraction, with your preoperative measurements, and, you know, then that's not, you know, that's not even good enough anymore. So.
Well, it's interesting work, and obviously the work that you're doing here is stuff that we all need to know more and more about, because we're seeing more and more of these patients, and their expectations are so high, and we need to be able to find ways to satisfy that. And you know, you're on the way to doing that. Appreciate taking the time to visit with us.
Thank you.
Yeah.